Thank you very much, sir, and thank you to AIOS for this platform. It's almost impossible to follow Madam in this topic particularly, but I'll try to share my very limited understanding of this topic of selecting the correct antibiotic and the rationale for choosing a particular antibiotic. So I think we all understand that antibiotics in ophthalmology are administered through different routes, and more the first two, that is the topical and the intracameral or intravitreal, are the ones which are most relevant, as has been realized that systemic antibiotics have a fairly limited role except in very special situations, and we'll be concentrating more on the topical antibiotics. So I think there are a few principles that we need to keep in mind before we choose an antibiotic, and just not rely on the brochures that the companies come up with, because if you go to the brochure of each company, you'll find this is the best drug in the world to be used. So I think we need to look at the mechanism of action that the drug is acting on. We need to critically review the peer-reviewed literature and the susceptibility pattern, particularly in the region that we are practicing. Like Dr. At the LV Prasad Arvind group, they've all shown quite a few differences than what will be published in Western literature. And it's also important to note the type of disease that you're treating. The involvement of the different ocular structures may coexist, and it may not be limited to one structure of the eye. And the reason why we want to choose a correct antibiotic is that because if we don't treat the infections in time, keratitis can easily spread into endophthalmitis, and can cause a loss in vision with the increasing drug resistance. Over a period of time, Western literature has shown that the gram-positive organisms are the most common organisms causing infections. Uh, we realized that in the Indian literature, until few years back, it was mainly the gram-negative that were being considered to be more causing the organisms, causing the infections, almost a 50-50 spread. However, like Madam showed, the publications, recent publications from Madam at the LVP group and other groups have shown that again the gram-positive infections are increasing as far as Indian bacterial isolates are also concerned. And also fungal infections are more on the rise compared to the gram-negative organisms. Another similar study from the Delhi infectious keratitis study also showed similar patterns of infection spread. Out of the various mechanisms, why is it important to know that a drug can act through different mechanisms? Because you want a drug which acts more often than not on the more important drug pathways, which are likely to affect or kill the cell organisms much faster and in a more efficient way, out of the several ways in which it can act. And for that, like Madam suggested, the knowledge of limited knowledge for us as clinicians of pharmacokinetics and pharmacodynamics is useful to make the decision. I think if we broadly separate the pharmacokinetics and the pharmacodynamics, from what I understand, pharmacokinetics is related to the body or the host. That is the absorption, distribution, metabolism, excretion of the drug, how much it penetrates in the eye, the maximum concentration, the amount, the area under the curve it stays for the X number of hours, so on and so forth. And pharmacodynamics is basically the drug itself, the properties of the drugs, that is the biological effects, the therapeutic effects, whether it's a single spectrum acting, broad spectrum acting, the minimum inhibitory concentration, and so on and so forth. And as far as the host bacteria interaction goes, it is this pharmacokinetics which relates to the host, and the pharmacodynamics that relates to the bacteria. The interaction between the two actually determines how this drug is going to act. Most of us as clinicians, until so far, like Madam highlighted, have known only MIC. And the moment some representative would come and say that this has the highest MIC, we feel this is the best drug. And it's partly true as well that the antibiotic with the lowest MIC value is considered to be the most potent. So lower the MIC, it means lower the amount of drug concentrate required to kill the maximum number of bacteria. And amongst the several studies, it has been shown over a period of time that the fourth generation fluoroquinolones have seemed to have a very good MIC potency against most of the common organisms, and not just the gram positive, but they have very good susceptibility even to the gram negative organisms. So it covers the almost entire spectrum of infections that all of us are seeing. The fallacy of using only the MIC, or the minimum inhibitory concentration data, like Madam suggested, is that it gives only the potency of the drug. It doesn't give any information regarding how long this drug is going to stay there, and how long it's going to act, for how many hours it's going to act in the body after a single dose, and how the rate of bacterial killing is going to be affected by the drug concentration, by either increasing it in the target tissue or by decreasing it. So, therefore, there are certain ratios which combine the principles of pharmacokinetics and pharmacodynamic, known as the PKPD indicators. And the three of the most commonly used for studies are the percentage of time of the free drug that remains above the MIC over 24 hours, the ratio of the maximum concentration of the drug to the MIC, and the ratio of the free drug area under concentration time curve to the MIC period. So, Madam very nicely highlighted the graph to show the importance of the MIC and the area under the curve, and the maximum concentration, the peak concentration that is achieved in the target organ. And it has been shown that the ratio of the area under the curve and the MIC is related mainly to the therapeutic effect, meaning higher the ratio, higher the therapeutic effect, and the ratio of the concentration peak to the MIC it determines how fast the organism is going to develop resistance to that particular drug. So you want an enhanced area under the curve and MIC ratio. That means that that drug is going to have higher therapeutic efficacy. At the same time, you also want a higher Cmax, that is the peak concentration to the MIC ratio, which means that it is going to reduce the chance of resistance developing to the organism, to the particular drug that you are using. And fluoroquinolones in general have been shown to exhibit concentration dependent bactericidal activity, and therefore most of the fluoroquinolones, particularly the fourth generation, have been shown to have maximum tissue concentration, and therefore higher efficacy of the antibiotic, and less development of resistance compared to the other antibiotics. But like Madam highlighted, the trends and things are changing in the last few years. I think the choice of antibiotic also depends on the site and severity of the infection. So you need to look at whether it's only a corneal involvement, or whether it's already has significant anterior, posterior segment, or scleral involvement. How much is the corneal involvement? Is it a small central single punched out ulcer? Is it spreading up to the limbus? Is it involving different areas? And like we said, that do you even consider strong antibiotics, or very selective, very extremely selective recalcitrant bacterial membranous conjunctivitis, which do occur particularly more in the pediatric population from time to time. If you have infection which is not only in the cornea but also spread into the structures inside the eye, it's important to also know the aqueous humor penetration or intraocular penetration of these drugs. And this was a study done, published way back in 2013 in Cornea, in the journal Cornea, I mean, which showed that the levofloxacin as well as the moxifloxacin both had good aqueous penetration after topical instillation of the drug. However, the higher concentration levofloxacin showed even more aqueous humor penetration compared to the 0.5% moxifloxacin. And another recent article just published a couple of years ago, was studied the aqueous humor penetration of high concentration levofloxacin and moxifloxacin in patients undergoing cataract surgery. So these were not infected patients, but samples were taken amongst these patients who were randomized to both the drugs, and it was found that the higher concentration levofloxacin achieved higher aqueous humor concentration. Coming to which drug to choose, and we've all learned from the LVP, Arvind, Ames, everyone, that uh, it's usually in the very severe infections, most of the organisms, particularly if they are drug resistant, don't respond to the commercially available eye drops, and therefore we have all learned right from our postgraduate days of choosing fortified antibiotics, that is antibiotics made from the injection drugs or the systemic drugs by mixing them into distilled water. So, in real life, it does work very well in institutes, in training centers, but in a single standalone private ophthalmic practice, fortified antibiotics do have a lot of challenges. First is preparation and contamination, that is the major risk factor. Second is because these drugs do not have preservatives, you don't know how long they are going to stay effective and not get contaminated by other structures. They need refrigeration, and they need frequent change of the drug and frequent making of the drug time and again, every 3 days or so. Whereas if you have a drug which would be as efficacious and still be commercially available in a drop form like normally patients and we as ophthalmologists are used to, it makes life very simple because it can be bought across the counter from a pharmacy. There are less chances of contamination because the bottle, the preservatives, everything has been designed to prevent that. And there will be no need for frequently changing the drug or frequently making the drug every 2 to 3 days or so. The AO in 2018 reported that the commercially available fluoroquinolones, the fourth generation, have fairly high effectivity rate in treating most of the bacterial infections, almost as equivalent to fortified eye drops. So I think to have a commercially available eye drop which would reduce the need for making fortified antibiotics for a standalone ophthalmic practitioner, I think is very, very important. Antibiotic resistance, like Madam suggested, I'm not going to go into the details, but as was correctly highlighted, the most common reason which we like it or not is us as ophthalmologists, because any red eye now, you see the prescription that the patient carries, there's always be a moxifloxacin in it. Whether it's a viral conjunctivitis, it's the season for viral infections, but still they'll be having a moxifloxacin. Whether it's just irritative dry eye, they will still be having moxifloxacin. And I think antibiotic steroid eye drops combinations have proved lethal over the last few years because, first of all, you don't need antibiotics for as long as the steroids, and you need to taper the steroids, but you don't need to taper the antibiotics. So I think these two is something that we as ophthalmologists need to take responsibility in trying to reduce the misuse. And another important point that most of us hesitate to talk about is the quality of the drug, because it's very, very important how what actually is in the drug is actually what is written on the label. So a drug which is effective needs to be of appropriate quality, appropriately made. And that brings us to the topic of branded versus generic. It's important for the audience to understand that generic is not just something which is made by a local company. So you have three categories amongst this. First is the innovator drug. That is the company that actually makes and innovates the drug. The second are what we call as branded generics. So once they are off patent, any company can make it and sell it under their own label, which we commonly see in India. And the third are true generics, where actually on the label you won't have any company name or anything on that. So most of the times what we confuse with generics are actually branded generics. And several articles have shown over a period of time that the drug concentration and the availability of these true generics is questionable in more than one situation. And therefore, I think selecting a cost is definitely a major issue and should be kept in mind, but that should not be the only criteria when we choose the quality of the antibiotic. So, having all gone through this, which is the antibiotic of choice, I think it varies, like I said, from all of the factors. And we want a drug which acts more, has faster action, less side effects, and more importantly, low resistance. So, I would like to conclude that we need to, make our choices based on evidence, on the literature that all of these brilliant, great institutes are coming out with. uh, we must acknowledge that the resistance to fluoroquinolones is of growing concern. So be careful and keep in mind when you prescribe a fluoroquinolone whether the patient actually needs it. Using more potent antibiotic formulations with the lower propensity of resistance may prevent less resistance from occurring less quickly. And the principles of pharmacokinetics, pharmacodynamics should be kept in mind before choosing a particular antibiotic. So I thank you all for your patient listening, and madam, my apologies if my concepts have not really been as thorough as yours.